esophagus, and these are the objectives of my presentation. And today, aim of extended lymphadenectomy is first is to accurately stage the disease, and second is for cure the patient. So accurate staging needs end stage. So end stage depends upon number of nodes. And according to Dutch randomized trial, mean lymph node yield almost double between transaortic versus transthoracic. That is 16 and 31%, 31 lymph nodes. And extended lymphadenectomy is having oncological benefit. Benefit is restricted to early lymph node spread, and it is absent in bulky and extensive lymph node positive disease. So in case of early lymph node spread, doing extended lymphadenectomy is beneficial. Extensive lymph node burden, there it's a marker of a systemic spread of the disease. So radical local surgery will not have any oncological benefit. So coming to short anatomy, this I think all of you guys know, upper thoracic, middle thoracic, and lower thoracic esophagus. So we'll come to lymphatic drainage. So basically mucosa is having no lymphatics, and lamina propria has densely arranged lymphatics which run longitudinally and limited circumferential. So lymphatic spread in lamina propria is longitudinal, and there is no lymphatic vessels communicating with intramuscular or extramuscular lymphatic vessels directly. So whatever lymphatics is there in lamina propria, first it will go to submucosa, then only it will go wherever it wants. Okay, next is muscularis mucosa. This is also having both oblique and longitudinal cross lymphatic spread. And coming to submucosa, our main part, that is lymphatic vessel in this layer, is generally located at the outer margin, and they have longitudinal flow, and occasionally they go for circumferential flow. Okay, so different lymphatic drainage pathway between submucosa and extramural system. What is the differences? Submucosal plexus can join to regional lymph node without relay in the intermuscular lymphatic system. So if the lesion is there up in submucosa, without invading the mural layer also, it can go to extramuscular lymphatic system. So one example is submucosal lymphatic flow repeatedly drain into the right recurrent laryngeal nerve node and occasionally into a subcarinal node. Okay, submucosal plexus can join to thoracic duct directly with a thick collecting vessels. It may join to intermuscular lymphatic plexus, which is connected to extramural lymphatics. So from submucosa, directly it can go to external lymph nodes, and it can go directly to thoracic duct, and it can reach the next layer, that is intermuscular lymphatic plexus, then it can go. Okay, so this is called two. One is direct spread and one is through the muscular layer. Directly it can go to recurrent laryngeal nerve node and thoracic duct, or it can go to muscle layer and then go to other nodes. So muscularis propria, the intermuscular lymphatic plexus is clearly visible and runs circumferentially. So in muscularis layer, circumferential spread is there. Till now it was all longitudinal, now it came to circumferential. It can communicate with lymphatics in the adventitia and extramural lymphatic nodes and thoracic duct directly. So this is the picture showing that. That is, first you can see in lamina propria and muscularis mucosa, there is a longitudinal flow and it will go to submucosa. Okay. These are the plexus which will go to submucosal level. This is not having any direct contact with extramural lymphatics or thoracic duct. Okay. Whereas you can see in the submucosal layer where this has having connection with the extramural lymphatics directly, and it through the submucosa it can go into thoracic duct also directly. Okay. Direct drainage to thoracic duct is restricted to the right and dorsal quadrant of the esophagus. This is the only important point here. And this is another same picture which will show that through the submucosal layer it will go directly into a thoracic duct and then regional lymph nodes. So this is very important concept, that is direction of the lymphatic drainage. The landmark is tracheal bifurcation. This is called watershed zone. Lymphatic from esophagus above the tracheal bifurcation drains superiorly to paratracheal, subcarinal and paraesophageal lymph nodes. It will go up. Lymph node below drains into mediasternal and left gastric lymph node. At the carina, it can go anywhere, either up or down. So this is the normal anatomy, what I said. Next we'll come to in case of malignancy, then one of the pathway might be blocked as shown in this picture. So the lymphatic spread, it, in spite of going upwards to the cervical region, it can go to the downwards and go to celiac group of lymph nodes. So the above mentioned direction of lymphatic flow may change when the lymphatic become blocked by a tumor, and the pattern of metastatic spread may not follow normal lymphatic drainage following the cephaloid spread of distal tumors. Okay, this can be vice versa, like lower tumor can go to upper region, and cervical tumors can spread to celiac lymph nodes because of the block in the lymphatics. So we'll come to importance of submucosal lymphatic network in nodal metastasis. So depth of the tumor depends upon the lymph node metastasis risk. In T1A tumors, there is 2.6% lymph node mets risk. This is given in Shackelford's. Okay, this data is from Shackelford's. T1B is from 22.2% lymph node mets will be there. T2 43.2%, T3 67%, and T4 77%. So we'll come to classification of lymph node status stations. This is the most commonly we know this classification. Okay, but Japanese classification, what we are will need read in next is little bit difficult. Might be easy for you guys, but for our like gastro people, we usually do this 1 to 20 station only. Okay, I think you guys know this, but I'll just briefly tell once. Station 1 is supraclavicular lymph node. Station 2 is paratracheal nodes. 3 is posterior mediastinal node. 4 is right lower paratracheal nodes. 4L is left lower paratracheal nodes. 5 is aortopulmonary. 6 is anterior mediastinal nodes. 7 is subcarinal nodes. 8 is paraesophageal lymph nodes. 9 is pulmonary ligament nodes. 10 is tracheobronchial lymph nodes. 15 is diaphragmatic. 16 is paracardial. 17 is left gastric node, 18 is common hepatic node, 19 is splenic node, and 20 is celiac node. Okay, we'll come to this Japanese classification. In this we can see they are classified into cervical lymph nodes, thoracic lymph nodes, and below abdominal lymph nodes. The continuation is there in next slide. So cervical lymph nodes 100 to 104. 100 is superficial lymph nodes of the neck. In detail I am not going because I can't write in exams. Okay. You guys can do it. And thoracic lymph nodes 105 to 114. Okay, and abdominal lymph nodes ranges from 1 to 20. So cervical lymph nodes 100 is superficial lymph node, 101 is paraesophageal lymph node, 102 is cervical lymph nodes, 103 is peripharyngeal lymph nodes, and 104 is supraclavicular lymph nodes. So for us important is 100, 104 and 101. All the paraesophageal lymph nodes are removed when it is of station 1. Okay, and thoracic lymph nodes, 105 is paraesophageal lymph nodes, 106 it's all about recurrent laryngeal nerve in and around it, and 7 is subcarinal, 107, 108 lymph nodes, 12 is lymph nodes along the pulmonary ligament, 13 is lymph nodes along the aorta, and 14 is anterior mediastinal lymph nodes. And abdominal lymph nodes we know because we are like used in CS stomach staging. So like we know, means gastro people know. Onco, if you are preparing for onco, then you will be knowing everything. Even thoracic lymph nodes. Okay, and abdominal lymph node, 1 is right paracardial, 2 is left paracardial, 3 is lesser curvature, 4 is along the greater curvature, 5 is suprapyloric, 6 is infrapyloric, 7 is left gastric artery lymph nodes, 8 is along the common hepatic, 9 is along the celiac artery, 10 is along the splenic hilum, 11 is along the splenic artery, 12 is hepatoduodenal lymph node, 13 is retropancreatic lymph nodes, 14 is superior mesenteric, 15 is middle colic, 16 is abdominal aorta, and then 17 is anterior surface of the pancreas, 18 is inferior margin of the pancreas, and 19 is infradiaphragmatic lymph node, and 20 is esophageal hiatal lymph nodes. So now we'll come to what are the group 1, group 2 and the group 3 lymph nodes. Standard 2-field lymphadenectomy means we should remove group 1 and group 2 lymph nodes. Okay, this differs for different location. Okay. For cervical group of lymph nodes, 101, that is cervical paraesophageal lymph nodes. Whatever is coming in first, no, it's all paraesophageal lymph nodes only. Paraesophageal lymph nodes in cervical region, upper thoracic region, middle thoracic region, and then lower thoracic region. It's all coming like that. So in cervical region, we should first group of lymph nodes is paraesophageal nodes and then recurrent laryngeal nodes we should remove. Upper thoracic, it is paraesophageal nodes and then upper thoracic paraesophageal nodes and 106, that is recurrent laryngeal lymph nodes. Middle thoracic is also same, recurrent laryngeal nerve nodes and then middle thoracic paraesophageal nodes. In lower thoracic 110, that is lower thoracic paraesophageal nodes and then right paracardial, left paracardial, lesser curvature and then along the left gastric artery nodes and then 20, that is around the hiatus. These are the group 1 nodes. Okay. So extent of lymphadenectomy. The 3-field lymphadenectomy includes upper abdomen, thorax and lower cervical regions.
इस वाले को हटा दो ना, इस वाले को नहीं.
Okay, the consensus conference of the International Society for Diseases of the Esophagus defined 3 types of lymphadenectomy. That is standard lymphadenectomy, extended lymphadenectomy and total lymphadenectomy. 3-field lymphadenectomy adds resection of bilateral cervical nodes to the total lymphadenectomy. Okay, this is the picture showing standard mediasternal lymphadenectomy. First picture, that is below the level of the carina, we are removing all the mediasternal lymph nodes. Okay, extended mediasternal lymphadenectomy, that is on the right side of the bifurcation of the trachea, we are removing lymph nodes along the right recurrent laryngeal nerve. And total mediasternal lymphadenectomy, here we are removing both right and left side of the recurrent laryngeal nerve lymph nodes. Okay, along with lower mediasternal lymph nodes. So extent of lymphadenectomy dissection.
अपर इसका लैंडमार्क क्या रहता है, सुपीरियर वाला?
This is lymph nodes along the right recurrent laryngeal nerve and it's written like if recurrent laryngeal lymph nodes are positive on right side, then there is a higher chance of spread into the cervical lymph nodes. So at that time we will do standard 3-field lymphadenectomy. Right now whatever like recommended things, that one is there. Okay. And this is they have just told lymph nodes along the right recurrent laryngeal nerve. No mention about landmark and all. I didn't get any findings on that.
Okay.
Okay. D1 is complete dissection of group 1 lymph nodes. This is what I mentioned previously. And D2 is complete dissection of both group 1 and group 2 lymph nodes. And D3 is both all the 3 lymph nodes. So pattern of lymph node metastasis. The lymph node metastasis in the neck, it is most common in station 101. Okay, 101 I said already. That is cervical paraesophageal lymph nodes. Okay. And station 101 is generally the uppermost collecting lymph nodes. Okay, and in the mediasternum, lymph node metastasis rate for 106, that is in and around the recurrent laryngeal nerve, is most common. Higher lymph node metastasis rate for station 106 recurrent laryngeal nerve are okay. For all thoracoesophageal cancer may be due to the direct drainage from submucosal lymphatic plexus and well developed right paratracheal lymphatic chain, that is PLCs, right paratracheal lymphatic chain, which is more commonly nicely developed than left side. The recurrent laryngeal nerve has a high cortical proportion and few macrophages with hyalinization. Okay, like all these macrophages are there in the right recurrent laryngeal lymph nodes, which facilitate and trap the migrating cancer cells. Okay. And abdominal lymph node metastasis usually most commonly occurs in 7th, that is along the left gastric lymph nodes. Okay, and paracardial lymph nodes should be another crucial relayed lymph node area also. So here comes a new thing that important thing, that is indication for 2-field versus 3-field. 3-field lymphadenectomy, it was never used in Europe for squamous cell carcinoma or adenocarcinoma. Only a selected group for study purpose only it was used, because
चंदना
large.
इसको हटाओ ना.
Okay, side का.
वो अच्छा नहीं दिख रहा.
So in large geographical differences in Europe, transhiatal versus transthoracic is still under debate. Transhiatal with limited lymphadenectomy mainly focuses on decrease of postoperative morbidity and mortality. So we know that transhiatal decreases post-op mortality and morbidity, whereas transthoracic with extended 2-field lymphadenectomy attempts to improve the radicality of the resection and thus increase the locoregional tumor control and long-term survival. And transthoracic esophagectomy is, however, associated with increased post-operative morbidity. Even the study extended transthoracic resection compared with limited transhiatal resection for adenocarcinoma of esophagus said the same. That transhiatic was associated with lower morbidity, transthoracic with an extended lymphadenectomy at higher morbidity. Okay. So, for lesion at or above the level of carina, transthoracic esophagectomy with 2 or 3-field lymph node dissection is mandatory, followed by cervical anastomosis. For adenocarcinoma below the level of the carina, either transthoracic with intrathoracic anastomosis or transhiatal can be performed depending upon the surgeon's preference. Some advocate the transhiatal esophagectomy can only be performed for tumors extending not more than 5 cm from distal esophagus. For adenocarcinoma involving the esophagogastric junction or gastricardia, a survival benefit for transthoracic over transhiatal has never been proven. So important is, in the case of squamous cell carcinoma, we can do extended lymphadenectomy. For adenocarcinoma of the lower esophagus, there is no need of doing extended lymphadenectomy. The standard mediastinal lymph node dissection is enough for that. So this group, that is Leuven group approach in Belgium, in that transthoracic esophagectomy is mainstay of treatment for all tumors of esophagus, and GEJ, as it allows probably the best chance of complete resection, optimal lymph node dissection and improved survival. Minimally invasive esophagectomy using transthoracic esophagectomy in prone position is procedure of choice. Bulky tumor along the airway before after neoadjuvant treatment and hybrid resection with right thoracotomy is also done. In this, extended 2-field lymph node dissection with frozen section of recurrent laryngeal nerve is demanded necessarily to decide whether 3-field lymphadenectomy should be performed. Means they did transthoracic esophagectomy and did sentinel lymph node biopsy of the recurrent laryngeal nerve. So if the recurrent laryngeal nerve lymph node is positive, then they went for standard 3-field lymphadenectomy. That is, they removed the cervical lymph nodes also. Proximal tumor or lymph node involvement in cervical region prior to neoadjuvant treatment or during the surgery, then also they did 3-field lymph node dissection. Okay, tumor invading the stomach more extensively for more than 5 cm along the lesser curvature, they did total gastrectomy. Okay, and advantage of 3-field lymphadenectomy. One study was there by Akiyama, a landmark paper for long-term survival in 3-field lymphadenectomy. In this, it showed that R0 resection was analyzed, and 5-year overall survival was 37.1% and 52.2% respectively. Okay. And 3-field lymphadenectomy led to 25% 5-year survival in subgroup of patients with positive cervical nodes. Says a lot about the radical procedure. Another by Altoriki, 3-field lymphadenectomy for adenocarcinoma of esophagus reported overall 46% 5-year survival. Incidence of cervicothoracic node metastasis for adenocarcinoma was 37% in this group, and 5-year survival was remarkable, that is 15%. Usually 5-year survival for adenocarcinoma it is given 0 to 1% and all in our textbook. So after this 3-field lymphadenectomy, it increased, that they are telling. Importance: due to retrospective nature of these series, the phenomenon of stage migration can be there. The beneficial effect of 3-field lymphadenectomy seem to be restricted to the patient with low burden of metastatic lymph nodes. The effect of improved survival disappears as long as the number of positive lymph node increases behind the threshold. Unfortunately, this threshold has been defined differently by different authors. Akiyama found that patients with squamous cell carcinoma and N plus stage after 3-field lymphadenectomy, those with more than 7 positive lymph node had low survival despite the radical procedure. So what we use is selective approach. That is, first we will look for site of lymph node involved. 3-field lymphadenectomy appears to be beneficial if the tumor is there in upper or middle thoracic tumors. No consensus on the routine application of for lower third tumors. That is what I said. Squamous cell carcinoma, upper and middle third tumors will do 3-field lymphadenectomy. For lower third tumors, standard mediastinal lymph node dissection, 2-field lymph node dissection is enough. Number of lymph nodes involved. One study by Nakagawa and colleagues concluded that cervical node dissection is only beneficial for patients with cancer of the upper and middle thoracic esophagus and with less than 5 positive lymph nodes taken. So depth of the tumor. Well, there is no role in early superficial esophageal cancer. It has a role in tumors behind T1B up to T3. The incidence of cervical node involvement when the tumor invades up to submucosa has been over 15%. So image-based selective neck dissection based on a fairly accurate and sensitive cervical ultrasound, which showing direct cervical lymphadenopathy, we can do cervical lymph node dissection. And sentinel lymph node base, that is mediastinal recurrent laryngeal nerve is positive for malignancy, then we can go ahead and remove the cervical lymph node involvement. Then they have also stated that cervical lymph node involvement is between 41 to 52% as compared between 10 to 12% for recurrent laryngeal node is free of tumor. So if the recurrent laryngeal lymph node is positive, then 41 to 52% it will be positive cervical lymph nodes will be there versus 10 to 12% if it is negative. So another study, that is characteristics and clinical significance of recurrent laryngeal nerve lymph node mets in esophageal squamous cell carcinoma, showed that metastasis to recurrent laryngeal nerve lymph node is reliable indicator of cervical lymph node metastasis in middle and lower thoracic esophageal cancer. Recurrent laryngeal nerve lymph node metastasis may act as a prognostic indicator for patients with esophageal squamous cell carcinoma. And this is a pattern of lymph node spread in squamous cell carcinoma versus adenocarcinoma. This picture is taken from Shackelford's. In case of squamous cell carcinoma, more lymph node spread is there in and around the tracheal bifurcation, and so right-sided recurrent laryngeal lymph nodes will be usually involved. And in case of adenocarcinoma, then lymph node along the hiatus and then along the paracardial region is more commonly affected. So for distal adenocarcinoma of esophagus, distal esophageal adenocarcinomas and type 1 sieverts can metastasize in more than 10% for supracarinal lymph nodes. Esophagogastric junction carcinomas with type 2 sieverts only do this in 1 to 2%. So sievert 1 metastasis to supracarinal lymph nodes will be 10%, whereas in sieverts 2 it is 1 to 2%. For all this sievert 1 adenocarcinomas and adenocarcinoma located in the thoracic esophagus, an extended or total lymphadenectomy should be considered. For type 2 only, mediastinal lymphadenectomy with subcarinal lymph node might be sufficient. So sievert 1 and distal esophageal carcinoma, external lymph node dissection can be used. For sievert 2, standard 2-field lymphadenectomy with subcarinal lymph nodes we can remove. So we'll come to skip metastasis. That is metastasis to anatomically distinct lymph nodes without metastasis to direct environment are known as skip mets. Skip metastasis can develop early in the phase of lymphatic invasion in patients with esophageal cancer. So early also it can develop. Regardless of primary tumor location, 20 to 40% of the patients with esophageal cancer have cervical lymph node metastasis, irrespective of the primary tumor location. That is, it can be in distal esophagus, OG junction tumor, but 20 to 40 it can go to cervical lymph node. In up to 50 to 60% of esophageal cancer, metastases are found in lymph nodes of the second or third anatomical compartment, skipping the lymph nodes of the first compartment. And number of lymph nodes, all we know that NCCN 15 nodes and Dutch guidelines also said 15 nodes, but German S3 guidelines tells 20 lymph nodes should be removed. And lymph node ratio. Lymph node ratio of metastatic to total lymph node has been shown to be a prognostic factor in esophageal cancer, but the value that is most predictive for survival is not clear. Most quoted figure is 0.2 to define the adequacy of lymphadenectomy, but various ratio from 0.1 to 0.3 have been proposed. Lymph node ratio has been shown to be more accurate for inadequately staged patient. So if we have already removed more than 15 lymph nodes, then it is of less important. If less than 15 lymph nodes is there, then lymph node ratio is more accurate. So arguments for extended lymphadenectomy is oncological benefit is there, staging will be improved, and then lymphadenectomy according to location or histology of tumor. Early carcinoma, skip metastasis, and micromets will be there, which we can remove in extended lymphadenectomy. So against lymphadenectomy is there is no level 1 evidence of oncological benefit, and high mortality and morbidity will be there. Quality of life will be altered, and decreased quality of life will be there. Regional or systemic disease, as cervical mets may be a marker of already and systemic disease. So removing cervical lymph node will not matter more like that. In cervical is cervical dissection necessary? Some studies found low incidence in lower third and G junction tumors. So in G junction, we always go for standard 2-field lymphadenectomy. Learning curve of 3-field lymphadenectomy is also there. So after 3-field lymphadenectomy, there is high mortality and morbidity. For 3-field lymphadenectomy, operative mortality is 0 to 10%. Overall morbidity is 46 to 80%. And major complications include pulmonary complication 22%, recurrent laryngeal nerve palsy 20.3%, more common on the left than right. So in summary, according to Japanese guidelines, 3-field lymphadenectomy for esophageal tumors in thorax we should do. 2-field lymphadenectomy for G junction tumors we should do. For squamous cell carcinoma of esophagus, 2-field versus selective 3-field based on recurrent laryngeal nerve node involvement should be considered. So if recurrent laryngeal nerve on the right side is positive, then we'll go for complete 3-field lymphadenectomy by removing cervical lymph nodes. For adenocarcinoma of esophagus, infracarinal 2-field versus 2-field lymphadenectomy, total 2-field lymphadenectomy based on extensive mediastinal lymph node involvement. If there is extensive lymph node involvement, then we are removing both on right side and left side upper mediastinal lymph nodes along the recurrent laryngeal nerve. So minimum 15 lymph nodes should be resected if no preoperative neoadjuvant therapy is given. And after neoadjuvant therapy, we don't know what is the definite number of lymph nodes should be removed. And 2-field is a minimum lymphadenectomy should be done. And sentinel node navigation based on lymphadenectomy is still an emerging topic. Okay.